Okay, are we ready?
Yep, you're right.
Okay. All right. Thanks, everyone, for being here on a cold, chilly Thursday night. Yeah. And thank you all to Zoom, and thank you, John, for inviting me. So it's really an opportunity tonight for our conversation, and wonderful that we're a small group because we can really like dive in. So pelvic and sexual health issues show up constantly in functional medicine practices, but many of us never got training in this area. So again, tonight, it's not really a lecture, it's a conversation. So everything we cover connects to the three systems that many of you already work with every day: urinary, bowel, and sexual health. So my goal is simple: help you to recognize pelvic floor patterns quickly. And again, ask me anything along the way. Oops, okay. So we're going to learn about what the pelvic floor does, how pelvic floor muscle tone and pelvic floor motor control will drive symptoms, how hormones, blood flow, and brain chemistry shape sexual health, and hopefully we can integrate your real patient cases throughout. So what does the pelvic floor do? The pelvic floor is the intersection point of urinary, bowel, and sexual function. If it doesn't relax, we have incomplete bladder emptying, urgency, constipation, pain with sex. If it's overactive, your patients they'll complain of burning, pressure, tailbone pain, GI symptoms. If it's underactive, you may have leakage or prolapse. And every symptom that we're going to talk about will trace back to one of these three systems: urinary, bowel, and sexual health. So I'm curious, like, which ones do you see in your practice when we're talking about urinary, bowel, and sexual health? What are big concerns that come up for those of you that are treating those things?
I see a lot of postmenopausal women with bladder spasms
Okay.
and also frequent UTIs.
Great. I mean, I'm sorry for them, but
Right.
great.
And recently I saw 2 women in the last month who've had these implants put in to prevent these devices they're implanted in to prevent their bladder spasms.
Have they been helpful?
One woman said 25% less spasms. One woman she gets up like, instead of getting up 8 times a night due to her spasms, now gets up 4.
Okay.
So it seemed like kind of a drastic thing to do, but
Yes.
it was
Yes.
done when
When
saw
she
them
came
the
to you,
first time.
right, right. So the question is about recurrent UTIs and bladder spasms and waking up multiple, like nocturia in postmenopausal women, for those people that maybe didn't hear your question. Um, so that's a great question. So a big driver of recurrent UTIs is compression of the main nerve that innervates the pelvic floor. It's called your pudendal nerve. The root of the word pudendal, does anybody know what that is? Anybody know Latin? Means to be ashamed of.
Mm.
Oh, God is right. Yeah, I mean, I hope there's a doctoral student doing their dissertation on that. Anyway, so what happens within the pelvic floor is that when that pudendal nerve or other pelvic floor nerves get compressed or irritated, they can cause burning with urination, increased urinary frequency, burning, all of those kinds of things, that symptoms that mimic a UTI. And a lot of times and these are people where like the dip in the office is negative, the cultures are negative. We are all taught you treat them empirically, and they don't have an infection. They have tight pelvic floor muscles. So we're all familiar, if you hit your ulnar nerve, you have pins and needles or tingling. And what we don't learn about is that when those nerves of the pelvic floor get compressed or irritated, what they produce is they can produce vaginal discharge, sweating, redness, like a rash, and then the burning, the urinary burning, the increased frequency, and even incontinence sometimes. So that's a huge missing piece of how the pelvic floor connects to recurrent UTIs. And in postmenopausal women, and perimenopausal, and we could talk about it more, but our patients have to be on vaginal hormones. They have to be on vaginal estrogen at a minimum, because that is in and of itself will reduce our postmenopausal women's UTI risk by 50%. And you need the role of hormones in the pelvic floor. They're intertwined because you need the hormonal support so that the pelvic floor muscles can function optimally. So those are two things before ever implanting anything. Like I would want her to have a great pelvic exam. I would want her to go to pelvic floor therapy, and I would really want to take a great look at her vulva and at the vagina and look at the tissue health. So we're going to get to a little later, but here's my crocheted vulva, my vestibule. This is my vulvar vestibule. So this is my crocheted vagina. Always a good time to bring it out. So the big thing here, and John and I were just talking about this, is that this tissue in between your labia minora, that's your vestibule. This is mediated by hormones, testosterone, androgens, and estrogen. And when this tissue is dry, it makes all of the pelvic floor muscles tighten and shorten. And when that happens, when the muscles are tight, they're going to compress or irritate the nerves of the pelvic floor and produce symptoms for your patients that mimic a UTI. So that's why it's so important. Even your patients on vaginal estrogen tablets, the vaginal ring, that's great for the inside, but it doesn't touch the vestibule. So that's an excellent question. Of course, yes.
Is it true that after you put someone on systemic therapy, sometimes you can peel the vaginal away? Or do you keep them on vaginal the whole time? Sometimes I've heard to bridge
Yeah.
vaginal estrogen and like a topical patch
Uh-huh.
initially, and
Yeah.
then sometimes you don't need the vaginal estrogen.
No, you always need, oh, well, it depends on your patient.
Mhm.
Systemic estrogen for some patients, can do a pretty good job of the lining of the vagina. Systemic estrogen cannot help you with your vestibule outside. It can't help you with your clitoral hood, right? Like so many people with clitoral pain, diminished orgasm, inability to orgasm. When you go to check their clitoral hood and you check the glands, this is the glands right here, is dry, and then the hood doesn't move. You got to have full clitoral hood mobility in order to have an orgasm. So, and the systemic estrogen, at least in my clinical experience, falls way short when you're talking about the external GU system.
Okay.
Yeah. You're very welcome. Good question. Okay. So high tone pelvic floor, it's like just like you can get tight muscles anywhere in your back, in your neck. We're all familiar with that. You can get tight muscles in your pelvic floor. You can get trigger points in your pelvic floor. And so these are the patients that will have, again, the bladder urgency and the frequency. Constipation, bloating is hugely connected to the pelvic floor. They can have entry pain, pain with penetration. They can have deeper pain. They can have pain with thrusting. Um, so the important part here is that the pelvic floor muscles have tone, just like any other muscle in the body. Now, how many of you guys do pelvic exams?
Absolutely.
Okay. But like actually like assessing the pelvic floor muscles. Okay. So,
I'm not an expert.
you don't need to be an expert. So I'll invite you to, and you're not doing you're telehealth,
I
right?
just started seeing people in person,
Oh.
so I will be.
Oh, perfect. Okay.
Yeah.
So there's so much happening on the way to the cervix, right? When you do a pap smear, when you learn about how to do a pelvic exam, you're ruling out a disease process, right? You're ruling out like, you're doing the pap smear, you're ruling out STDs, you're looking for cervical motion tenderness, you're looking for adnexal tenderness, right? It's really focused on the disease, and it has to be. And I'm not saying don't do that, you have to. But you have to put your finger into your MCP, this joint, in order to find the cervix, right? That's a lot of real estate. The vagina is about 3 inches wide and 9 inches long. Surrounded, I always explain it to my patients, your vagina is like a hallway, and if you have tight pelvic floor muscles, the hallway gets a lot narrower, and that's why it hurts to put something inside. We, with our index finger, can palpate everywhere within the pelvic floor. And so if you hold up your index finger, your DIP corresponds to the superficial layer of your pelvic floor muscles, right? So you just go in, it's very superficial. Your PIP is the second layer of pelvic floor muscle, and your MCP is the third. And we can palpate all that. Just like if someone comes in with back pain and you're palpating along their spine and you're looking for spasms, you're looking for trigger points, you're looking for tender spots, you can do the same thing once you connect the dots that, wow, the pelvic floor has muscles too. So that's the invitation there, is that the pelvic floor has muscles just like anywhere else, and they become dysfunctional, right? And so something that's, I think the pelvic floor is having its moment, right? Like it's more in the news, and everybody associates the pelvic floor with Kegels. So I would like everyone to associate the pelvic floor with diaphragmatic breathing, because uh, when the diaphragm descends, the pelvic floor relaxes, and everyone benefits from pelvic floor relaxation. Kegels are strengthening. And if your patient has tight pelvic floor muscles, the last thing you want to do is make those muscles even tighter by just contracting, contracting, contracting. So my dream is that when we think about the pelvic floor, people will be like, oh, take a deep breath. Because again, as you can see by the arrows here, when we take a deep breath, the diaphragm descends and the pelvic floor relaxes. And that is the foundational hallmark of optimal pelvic floor health. I will also say you cannot strengthen muscles that you cannot lengthen, right? You have to be able to relax in order to build strength. So everyone benefits from diaphragmatic breathing, and everybody needs to be doing it. So, and I'm pretty sure I'm preaching to the choir when it comes to that, as you're all functional medicine providers, right? We're looking for root cause. We're trying to calm the nervous system. We're trying to oxygenate the body. How do you put like 6 times more oxygen into your circulatory system when you breathe with your diaphragm, and you're helping your pelvic floor. Okay. So, oops, I think, did I? Oh, yes. So the three biological pillars of sexual health. So we're all like we all know about the biopsychosocial model of healthcare. And I feel like we've fallen very short on supporting women, people with vaginas, with the biological part of sexual health. And so I think of three pillars, and these pillars help to explain why sexual symptoms show up with perimenopause, menopause, certain medications, chronic stress, trauma, pelvic pain, and even cancer survivorship, because all of these things are impacted, right? So think about the biological part of sexual health. It's a three-legged stool with blood flow, hormones, and brain chemistry. Another reason why all of our postmenopausal patients should be at a minimum on vaginal estrogen and topical, so that you're getting the vulva, because these are your patients. You have patients that come in and start to complain of, well, sex never hurt before and now it does. I never had pain at entry and now it does. This skin will get so fragile and so dry that I literally see micro tears in the skin. I don't know if you have seen that. I mean, think about that. Like, that's so painful, like massive micro tears. And what I will say is that for those patients, the estrogen does a pretty good job, but you really need to add in the testosterone. Because remember, this tissue has androgen and estrogen receptors on it. So when we treat with only estrogen, it's not enough. Those are for the people with the significant entry pain, that micro tearing. They're talking about, like, I feel like I've got knives when something's trying to go inside of me. Um, so that's the hormone piece.
I'm sorry
Oops.
to interrupt. You
Yeah,
said
no, go
for
right
the
ahead.
Patients with the knife-like sensation,
Yep.
that's, you want to be sure that you're doing the combo testosterone plus.
Well, you want to do a great exam, and you want to look. First off, you got to look at the vulva, right? And you got to see that. I always, I always give my patients a mirror. It's a mirror it's like a curved mirror so that they can hold it if they want to look with me. And I always say, I'm looking for glisten and I'm looking for glide. So with my gloved finger, and we all know in like a very healthy reproductive aged person, when you look at the vulva, it's like it glistens, right? And if you take your gloved finger, you'll be able to just go like, and it'll just glide right down the tissue. So I always say glisten and glide. And once you start to look at the tissue that way, you'll start to notice like people with significant dryness, you can't go like that. You just can't. And so I also find that those are words that patients can sort of understand because it's hard, like nobody knows. Patients have no language for a dry vulva. They don't, right? Because we don't know what it is. Is that helpful?
That is helpful.
Okay.
I'd love to know too,
Yeah.
how you're approaching the digital exam, like what you're doing when you are
Internally, like a
internally.
bimanual exam.
Yes,
Yeah.
what's different than what you would do, typically for like a PAP or like.
I assess the pelvic floor muscles
Okay.
and I ask them to contract and I ask them to release. And first I ask them to breathe with their diaphragm. And so if this is my examining finger, these are their pelvic floor muscles. Then, when you're inside, it feels almost like a gentle hug. Sometimes it'll feel like a vice grip if you've got a lot of tension. I ask them to breathe. You want to feel space created around your finger. That's the big thing. Then you ask them to just exhale normally, and you should feel that resting tension again. And then you ask them, yes, yeah, they have to do it a couple of times because people, it's a pelvic exam. Like people are nervous, and so when you do your Q-tip exam, that's the exam for the vulva, or you use your finger and you go all around the vestibule. And we think about the pelvic clock. I'll get back to your bimanual in a second, but you think about the pelvic clock. So up here at 12 is the clitoris, down by the bottom of the vaginal opening is 6 o'clock. And then with your index finger with a Q-tip, you have to go around multiple times and assess for where is it tender. Because the first time they'll be like, oh, yeah, yeah, yeah. And then they relax a little bit and then you do it again. And that's really what your exam findings those are your accurate exam findings. And while we're on the topic, if you have tenderness between 4 and 8, that's usually overactive or tight pelvic floor muscles. All the pelvic floor muscles attach. That's one of their attachment points. So I think that's a helpful clinical pearl. And then when you go inside, that's where using your index fingers, the joints of your index finger to know where you are inside. And again, just like you're palpating for anything else on externally from a musculoskeletal point, you can do the same thing on the inside. Yeah. And if it's helpful, like I have a ton of resource, my pelvic floor PT colleague and I have developed an entire continuing education course on assessing the pelvic floor and all the stuff we're talking about because nobody knows about it. And like I never learned any of this. And then I did, and I was like, wow, did I miss this in school? Was I sick that day? Like what happened? And the answer was no. Whenever you hear pelvic floor, you hear Kegels. And it's so much more. And there's so much that for you who are doing the pelvic exams, this is within your wheelhouse. Like you don't necessarily have to treat in that moment, but if you can identify for your patient that's having the recurrent UTIs, and when you're doing your bimanual exam, your digital exam, and you're recreating like some of their symptoms, that's an incredible aha moment for your patient. First of all, you're validating their symptoms, which is the best. And then you're like, oh, wow, it could be a tight muscle. And then if you do make a referral, they're much more likely to go because you've just connected some dots that have never been connected for them before. Um, Any other, I guess I'm curious, like people you see sexual dysfunction, you see dyspareunia, like all those kinds of things. Does anything like any clinical cases come to mind while we're on the topic of sexual health? Maybe they'll come up later. I don't know.
What are your thoughts on dyspareunia in like a younger patient, so somebody in their 20s, and it's not hormonally driven? What are you thinking about there?
Well, you always want to ask, is it entry pain? Is it deeper pain? Is it pain with thrusting? Pain with thrusting a lot of times you start to think about endometriosis, right? Because there might be endometrial implants that are, exerting a pressure that then as soon as the vaginal canal has to start contracting, it's like coming up against some of those endometrial implants. These are generalizations. So you always want to ask about a really good history around menstrual history. Um, if they're like, is there when they get their period, is it affecting their ADLs? Like, are they missing school? How heavy is their period? It's because we've done a terrible job, but women think that it's common to have like super debilitating periods. We've normalized it and it's not, right? So there's just like, and I'm happy to talk more about like, I really dive in for the endometriosis questions because you can pretty much tell if someone has it just based on your questioning. And the only way to diagnose this is to go in laparoscopically, and that's hard. That's hard. So, and there's so many things from the functional medicine perspective that are you can do because I do take care of patients that have had the endo excision surgery, and you still need a really good pelvic floor therapist and a really good provider who helps you to calm your nervous system, to like decrease the overall inflammation and all those kinds of things. So off topic of your dyspareunia, but dyspareunia in the younger patient. So deeper pelvic pain. So that's like when you're going to your like MCP or your PIP and you're palpating tender muscles, you need to do that. You need to make sure that that's not an underlying etiology. You have to do a great, like, what medications are they taking? Anything that's going to modify hormones, you have to think, what is it doing to the tissue of the vagina and again of the vestibule? People on, not everybody, but younger, anybody on a combined oral contraceptive pill. How does it work? It decreases your free testosterone and it increases your sex hormone binding globulin. That's part of the way that the combined oral contraceptive pill works. For most people, it's totally fine. My practice is full of people who it's not fine, and it dramatically affects this tissue of the vulvar vestibule because of the decreased free testosterone. So these are people that when you do your really thorough vulvar exam, you're going to elicit pain as soon as you touch. You're not going to be able to glide. There's going to be no glisten at all. And so that's always something I think about. We're going to go into it in a little bit more. It's hormonally mediated vestibulodynia, pain in the vestibule. It's a big thing that I never learned about in school. So does that answer your question? Or
It's also interesting how,
oh,
you have flashbacks of patients that you're like, oh, I wish I knew
oh
that.
my gosh, I know,
That was
totally.
like, I wish I asked about thrusting. I wish I
Yeah.
considered endometriosis for your, it's hard to know.
Oh, it's so hard to know, but you're asking now, like, and that's the thing that matters.
So when you have a patient that sees you and they're a younger patient or even 30s and 40s who's on birth control
Yep.
for perimenopause,
Yep.
does that make you flinch or you?
No,
Okay.
not at all. It's all based on my exam findings. Because again, a large percentage of patients do great on combined oral contraceptive pills. It's a very small subset of people that will have this tissue affected in their vestibule.
And would you just treat through with topical testosterone?
So
Or
it's a great question because we want our patients to be protected if they don't want to have a pregnancy, like that's a big deal. So I will often start, and these patients, you have to do estrogen and testosterone cream that John makes so much for me every day, all day long. And they need to do it, and they need to be doing it twice a day for it, like at least 3-4 months. And then you can reassess and maybe start to taper down a little bit.
so
And in
even
that
maybe
time, I would
first-
try to say, like, is there another method that we could think about?
Right.
Yeah. It's always you got to, it's like the risks and the benefits. You got to weigh. You don't want an unplanned pregnancy, first and foremost, but you also don't want to have pain. So it's complicated. Did that address your question?
Yeah.
Okay, great. All right, so it's all connected. So if we think about the main functions of your pelvic floor, it's urinary, bowel, and sexual health. And so when we think about the toileting mechanics really, really matter. It's a big deal. And the reason it matters is because from a mechanical standpoint, when you change, so if you look on the right and you see the anorectal angle, can you see that? It's like right, yeah. It's
That's what I was.
yeah, it's this. It's that, right? So it's like if you're standing from the side, right? This is your anorectal angle. This is what I always say to patients. So for anybody with constipation or like incomplete emptying or whatever, you got to change the angle, right? Like, yes, you have to work on the root cause of it, but part of the root cause could be just biomechanical. You have to change the angle. When the angle is like this, that's when your knee is in line with your hip, the person sitting on the left. And if you have tight pelvic floor muscles, you're not going to be able to pass the stool. Like there's no way. So as soon the reason we all you like love a squatty potty is because it takes this and makes it like this. It changes the angle. So then even if you have tight pelvic floor muscles, all of a sudden you've made a mechanical shift that will make it easier for the stool to pass. So I can't stress it enough. And if you can do it with books, you can do it with yoga blocks. Like you don't have to go and get the actual squatty potty. It doesn't matter how it's like we have to work with our patient to be able to change the anorectal angle. It's a big deal.
Would you recommend a squatty potty for a patient that doesn't have constipation as part of their pathology, or would you, it's just if constipation is part of?
So it's like, how hard is it for you to pass stool? I get the Bristol stool chart out 10, 20 times a day, right? And I'm like, show me where you are. Because if you say, what is your stool like? And they're like, it's normal. Everyone's like, it's normal. I'm like, And they think like Bristol 1, like pellet-like stools are normal. And it's like, they're not. They think the fact that they poop every 5 days or once a week is normal, and it's not. They think thin ribbon-like stool, like a Bristol 2 no, no. So I just get a really good bowel history and then make the recommendation based on that. But I don't, if you're a Bristol 4 and you fully empty and you're not having any pain and you're pooping every day, I don't think you need to worry so much about the changing the angle. Or maybe just you're lucky and your angle isn't so, maybe I don't know, your angle's working for you. I'm not really sure. But like that's the big thing is that if you look at the bottom, it's like, right, it's like that one of those pelvic floor muscles. It's called your puborectalis. How do we name the pelvic floor muscles? By where they're attached, right? So they attach at the pubic bone, that's the pubo. Then they attach at the rectum. That's why it's called the puborectalis. So that's how we name all of them. If you want to know them, great. You just have to know where they feel tight. It doesn't really matter that much, but that's how we name them. So that puborectalis muscle, again, it just chokes off the rectum, chokes off that rectal angle. So, okay. See, and then I haven't had a slide about this. Your question, right? So I think we talked about that, and there you can see like the yellow is the nerve and how it goes into the pelvic floor. Okay. And then we touched on it a little bit, but the clitoris is the most densely innervated structure in the human body, I think. Far more sensitive than the penis, and it's far more complex than most anatomical diagrams ever show. And so estrogen and testosterone both support the clitoral glands. Oopsies, sorry, wrong one. The hood and the internal structures. And again, you got to do a really good detailed clitoral exam for your patients with pain with sex, clitoral pain, persistent genital arousal disorder, muted orgasm, anorgasmia, any of it. You gotta, it's like you gotta look under the hood. You just have to. You can have dead skin cells will often pile up one on top of another under there, and they create keratin pearls. She's like, oh my God, right? I know. Well, think about it, right? Like if your hood is stuck, you're not gonna be able to have the orgasm that you want to have or even have an orgasm at all. So you gotta look, you gotta make sure. And you gotta have optimal blood flow to the clitoris. And if the clitoral hood is stuck, doesn't matter how much good blood flow you have, it's not going to be able to go all the way through. And the clitoris has legs, right? Like that's an interesting fun fact. You can pass it around. It's got legs, right? So here's because I'm on the video, but like here's the vagina, right? This is the vagina. The legs literally wrap around the tube of the vagina. When we get aroused, as these fill with blood and get engorged, it's this incredible choreography between the contraction of the tube of the vagina and the crurae, that's the word for them, or legs of the clitoris. So, fun fact. And then you can see, like, you've got to mobilize that. You can pass it around. It's helpful. I don't know.
Did you crochet those yourself?
I did not. No, I did not. I can't. Somebody asked me that. I was like, no, can't take credit. I do not crochet. So again, anytime our patients are on any kind of medication that modifies hormones, we need to ask the questions around sexual health, orgasm health, clitoral health, all those kinds of things. Aromatase inhibitors, selective estrogen receptor modulators. Even though if you like, people will say, oh, that a lot of clinicians will say that doesn't affect the vulvovaginal tissue, especially like the selective, because they're selective estrogen receptor modulators. They're not supposed to affect the vulva and the vagina. My practice is full of people who have severe tissue damage from being on those medications, and they need to stay on them, right? So it's like, how can we support our patients who need to be on some of these medications? So, and also the clitoris is, again, it's so vascular. So anyone with like clitoral pain, orgasm pain, anorgasmia? No. Nope. Okay. So again, I think it's if we learn two things, it's like you got to breathe with your diaphragm and your vulva and vagina need hormones. And then I have done my job. Because when you have decreased blood flow, it creates trigger points, burning pain, and the list goes on and on and on. Because the tissue integrity depends on hormones, right? And low estrogen, low testosterone can cause thinning, increased friction, micro tears, increased nerve exposure, higher sensitivity to irritants. And again, when the tissue is irritated, the pelvic floor tightens as a protective response. And then it causes all kinds of urinary, bowel, and sexual symptoms. So I will say one thing about lubricants while we're talking about vulvovaginal health. I'm super passionate about lubricants and the osmolality of your lubricant. It's something that should be on every bottle of lubricant that is sold, and it's not. I think if it were for penises, that would be on there, right? Like, because when the osmolality is too high, it literally of the lubricant, for example, like KY Astroglide, we know what the osmolality of the vagina is. It's about, I think it's like between 280 and 340 maybe milliosmoles per kilogram. We know that. Like all body fluids, we know what the osmolality is. And we know from the World Health Organization that once you go above 1200, that's when you see micro tears, you see sloughing off of the first layer of vaginal epithelium. The reason we know that from the WHO is because they studied STI transmission in sub-Saharan Africa. And as soon as the osmolality of the lubricant went above that, they saw an increase in STIs. So a lubricant like KY, Astroglide, they're all like in the thousands way above 1200 when it comes to that value. So you got to be really thoughtful about the osmolality of your lubricant. And this is something that it should be on every label. It's not, but now that you know, I'm happy if anybody wants, like I have a curated list of lubricants that are fine, that are not going to destroy the vaginal vault. You know, it's important.
What are your recommendations?
My recommendations. So there's 3 kinds of lubricant. There's water-based, which I really like slippery stuff, and that's what I actually use in my office. The osmolality is like 26, I think. There's that you have to order, right? So I'm always thinking about access. So you can get Good Clean Love. Problem with that, it's good. It's got aloe in it, and about 5% of the population has a sensitivity to aloe, so it will cause burning. So like I want to love that one, and I do, and that's an issue there. So that's for water-based and Coco New. That's a really nice company. They think a lot about the osmolality.
Coco New.
It's COCONU, Coco New. They make a nice oil-based one, right? So there's water-based, there's oil-based. Oil-based, you don't have to worry about the osmolality because it's only, you're talking about vaginal vault, which has water, right? And the water-based lubricant. It's how the particles move from one medium to another, and you don't have to worry about it with oil. The thing with oil is it doesn't work with condoms.
What do you think about coconut oil?
I think coconut oil can be fine. Um, it's okay. I think if that's what your patient likes, I think I want people to have options. And I think the Coco New, their oil one is a little bit thicker, and coconut oil can be a little bit thin. But if it works for you, it works for you. And then make sure they're applying it correctly, right? Whatever's going inside of them needs to have the lubricant. The vaginal vault needs to have the lubricant, and the vulva needs to have the lubricant.
The problem with condoms and oil?
It renders it, it just won't work. Like it like breaks down the condom. So then the condom's useless. And then there's still, so the third, what'd you say?
It's a good thing to know.
It's a very good thing to know. Yeah, no, totally. I know. My patient today just said, "Oh, I got some Coco New for my daughter." And I was like, "Oh my God, did you get her the water-based or the oil-based one, right? And did you tell her she needs to use condoms with that?" And then there's silicone-based. And that you don't have to worry about the osmolality either. And so there's a Uber Lube is a popular one. Kindra is another company that thinks a lot about this stuff, and they have a, you know, I think the rule of thumb is like as few ingredients as possible. No smells, no warming, no cooling, nothing. Like you don't need it, and it's toxic for your vagina. Okay. And then, oops, let's see. Sorry. Maybe my video. This is so I had to make a video for all my patients after the day that someone wrote to me and said, "Where do I put my vulvovaginal cream?" And I was like, "Oh God, okay." Anyway, I don't know. We had it working before, but it doesn't matter. So every patient that gets their estrogen or their estrogen and testosterone from John gets the accompanying video. It's probably in the slide deck, it'll work. But so you just, you do your one click and you take it and you like massage it into the vestibule and then you got to go up and mobilize your clitoral hood. Now, if there's significant dryness, sometimes I'll split it up and I'll do like like one click to the lower half of the vestibule and then one click to the upper half of the vestibule. You want to, if your patient can tolerate it, you really want to massage it into the tissue because you're improving the mobility of the muscle by doing that, and you're improving the blood flow. So if your patient can tolerate that, maximize it. You got to maximize it. They can get so much benefit. So like I will literally like I'll say, "Okay, is it okay? I'm going to put my hand like on your arm." Like you could go like this and that's fine, but you could really like massage it in and it's way better. And then you take another click. Again, if there's significant dryness of the vaginal vault, maybe you do 2. And then same thing, you got to go in and you got to massage it into the tissue because you need to, again, improve the blood flow and improve the mobility of the muscle. So if you're going to do it, do it. So So every patient now gets that after that email. And then vestibulodynia. So it's interesting. John and I were talking about this. There's no ICD-10 code for this.
Of course.
No, it's all like vulvodynia. I'm like, not really. Anyway, so there's 3 kinds of pain in the vestibule. Oops, sorry. So there is hormonally mediated, which we chatted about. And then there's inflammatory. So that's where you'll do your palpation and like the whole thing is just like they're like pain, 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 pain. And then there's neuroproliferative, meaning that just I always say to my patients, it's like your nerve endings are just like that. Like they're all firing and they're just overfiring and they're causing a lot of burning. And sometimes you can have you can have a lot of dryness and a lot of like the hormone balance isn't right in that tissue. And then once you get fixed, and you can only really fix one thing at a time, right? You got to go slow. You address that first, and then they still have some burning, and then you can address like the neuroproliferative or the inflammatory part. And that we use topical gabapentin, topical ketamine and amitriptyline, sometimes topical LDN. And it's so important that you can put it all in these bases that are pH balanced for this tissue, and that you have the option to put the medication into olive oil or coconut oil, or because so many of these patients are so sensitive to the excipients. And the inflammatory and the neuroproliferative vestibulodynia, in my world, everyone thinks there's like more and more chatter now about these are probably mast cell aberrant conditions. There's a urologist in San Diego who's doing vestibular biopsies and works with a particular pathologist and gets him to stain a certain way. And they're showing like proliferation of mast cells in the vestibular tissue. So it's super interesting. Do you guys see mast cell? Yeah. So, and mast cell's it's complex. And I know we have to treat it at its root. And sometimes you also need to give these patients the topical support. You can sometimes do that. Vaginal mast cell suppositories also sometimes will be super helpful for like IC-BPS type symptoms where it's not really IC, but it's somewhere on that mast cell spectrum. So I'm part of a sexual medicine group, and they requested, I literally just like a month ago did a whole course for them on genitopelvic pain conditions and mast cell. Because who are you going to send these people to? There isn't anybody. They're like, oh, refer them to allergy. Allergists won't touch GU concerns. They won't. Like, they're like, I don't know, and then it's like, well, if they don't, and then the testing is limited, right? Because the urine testing is only going to test for what, like 4 mediators and tryptase and the serum tryptase, like, but your mast cells release a lot more than that, right? And so then it's like hard to get patients to a mast cell clinic or an allergist. And so like, there's so much we can do. And like the dermatologist isn't going to help them with this, at least in my experience. And we live in Boston. So think about how like hard it is in other places, right? So it's good they have you. And now you know about this. Amazing. Um, any questions on that? No? Okay.
Yeah, I have a question.
Yes.
So if you're suspecting that there's mast cell as part of their vestibulodynia, you're suggesting that you would manage it, and how would you manage it differently than if it was just, what would you do differently with a mast cell if you're not going to send them to a mast cell specialist?
Person, yeah. Well, so I actually will manage the mast cell both systemically and locally.
So
I'll do
you
both.
would initiate if you had just that symptom, you would consider it and discuss that as a possibility. And
Well, remember with mast cell, it's never just if it's one organ system, right? Like you got to have 2 or more on your
Yeah.
review of systems. So if it's only one, I'm like, oh, it's like, and mast cell's a spectrum, right? Like it's a spectrum, like hypermobility. I see a ton of hypermobile patients as well. And these are spectrum. So if they have very targeted symptoms of the GU system, I will treat locally. as I'm also starting to treat systemically. Does that answer your question?
Yeah.
That would be, what would you typically use for things like that?
So I would use like maybe topical gabapentin, topical amitriptyline. If it's more internal burning, you guys would put those into a suppository for me. Ketamine and amitriptyline. Also doing, uh, what is it? I've lost it. The suppositories you guys make for me. The mast cell ones. Oh, yeah, cromolyn and catodafin. You can do topically. Yeah. Sometimes LDN can be helpful, and you just have to try. You just have to try. And it's hard. Like they're in so much pain. It's so hard. And again, sometimes the mast cell stabilizing suppositories like a catodafin, a cromolyn, and sometimes a singular will help a lot of people with the like IC BPS type of symptoms. So that's a suppository that John will do that they can insert vaginally.
A singular suppository.
Yeah, so you can do catodafin. I mean, that's where it's helpful if you do have the urine testing and the leukotrienes, they do have elevated leukotrienes, you would think about singular in there. I think in general, John, you could probably answer this, but I think like catodafin and cromolyn are broader, right,
Yeah.
than like the singular.
I think those are the main ones, and then,
Yes. But like if your patient had the elevated leukotrienes, and they had like a lot of vestibular burning and stuff, would certainly be worth a try. I think this putting the singular in also makes it a lot more expensive.
Yeah.
Which you have to think about, right? Because these are all out of pocket medications. And so I guess, let's see. So it's a treatment ladder when we're talking about pelvic floor overactivity, hypertonicity, or when the muscles won't relax. So I didn't put it in here, but when I do a ton of teaching and I have like a pyramid. And at the bottom of the pyramid, I have all the foundational stuff, the diaphragmatic breathing, the down training, the neural retraining, the MBSR, whatever it works for your patient, along with a good pelvic floor therapist. And then like as we go up the treatment ladder, then I will think about compounded suppositories, Valium, baclofen, amitriptyline, gabapentin, depending on what the particular symptoms are. And then at the top of the treatment ladder, I do Botox. I do vaginal Botox. So I will go in, identify the trigger points or the tender spots, and then directly inject with Botox into the pelvic floor.
How many patients do you see typically, like, let's say in like a 6-month period that would be at that level of treatment?
For the Botox?
Yeah.
Well, my practice is skewed because I see all the people that like have seen everyone else.
Yes.
So it's hard. I can't really answer that. It's hard to say. Yeah. Because I get all the people, they're like, I've been in pelvic floor therapy for, a long time. Like we've only progressed so far, like, and then they send them to me. So I have a unique perspective. I think most people do really, really well with all the other stuff, and then, but, some vaginismus, they just like, and I always say to people, it's like, you see the wrinkles on my forehead? Like that's your pelvic floor muscles. They're super tight. So when you give Botox, look at my wrinkles go away. And then it's the same thing, like your pelvic floor muscles, they just relax. They just like this big dose of a muscle relaxant, and it lasts for 3 months. And it allows the pelvic floor therapist to actually maybe begin to work a little more deeply into the muscle and tissue, because you're trying to like, do neuromuscular retraining. And when sometimes those muscles are just caught in like a massive spasm, it's hard. And a good pelvic floor therapist, and I work with amazing ones because I've trained them, they'll assess the whole body, right? Like that's how like a not so great pelvic floor therapist will treat like from the top of the hip to the top of the thigh. A good one looks holistically, looks at pelvic alignment, is thinking about balancing the external bowl of the pelvis. And, they're amazing. So you've got to find somebody that does the whole body. Otherwise, your patient is wasting their time. And most of the time, those people are out of network because, yes, Wellist, they're my favorites. They're called Wellist Integrative Health,
Wellness.
Wellest. Yeah. In fact, my practice is located within their office.
Okay.
Yeah. And like they know all this stuff. Because like they do amazing, they probably do a better vulvovaginal exam than like most like physicians do.
They're PTs.
And they love to learn. They invite me to their team meetings and I do in-services for them and it's so fun because they love to learn. And they're great. And myself and now we're sort of known as a specialty clinic for mast cell hypermobility, dysautonomia, endometriosis, all those overlapping things because like no one's helping these people. No one is like putting the pieces together in that way. Well, you guys probably are, right? So it's good for us to know about you too. This stuff is hard and it needs, what I always say is it's like, you need this wonderful quilt that supports you. It doesn't squish you, but it also doesn't leave you like hanging out with no support. And you need all the squares of the quilt. Right. So you need a good pelvic floor PT, you need a good functional medicine provider, you need someone like me who knows about the vulva and the vagina and the pelvic floor. So, all right. And then diaphragmatic breathing handout, both in English and Spanish, because again, it's the hallmark. It is the hallmark. And I also have a toileting position handout, so let me know when you're ready. We're ready. Look at that amazing anorectal angle, everybody. So good. So good. And then that's my contact info if you guys have any questions after. And then I think we're at 8 o'clock, so I don't know how people have questions or if we want to wrap oh, I will say one other thing for those of us that do speculum exams. Do you guys do speculum exams? Okay. So you're gonna laugh. I really hate social media. Like I think it's horrible and it's not my thing. And I have a wonderful assistant and she said, just start making me some videos like in between your patients or whatever. I'm like, oh, and I did it for like a month and then I quit because I don't like it. So you'll laugh. I made a video that she posted on TikTok that went viral about the size of your speculum, right? So the take home message is use the extra small. They come extra small through like extra large. Use the smallest one.
For patients that have,
I would say for anybody. Think about it, or at least a small, but offer the speculum is what I would say. And if you're worried about prolapse, is that like maybe while you're like, I can't do a small one?
I feel like sometimes I'm able to visualize the cervix better. It needs to be like big enough.
Because of the prolapse of the
Yes.
walls?
For most women, I feel like.
Okay, so what you do, you get a condom, you put it over the tip, you clip it, and you create your own vaginal wall retractor, and it pushes the walls out of the way. And I don't use the footrests. You don't need them.
You just, where do you have them there?
I have them just put their legs at the end of the table.
I mean, that just is so much more humane.
Totally. I have a whole, again, so my colleague and I, we have the Institute for Pelvic Health. We have a whole YouTube channel. We talk about all of this stuff, positioning on the exam table, all of it. You don't need it. You can have them be with the soles of their feet together and their knees wide.
Yeah.
Yeah. Or knees together and feet wide, right? Like it's so horrible to be like, and I used to run a sexual and reproductive health program. I did endometrial biopsies, IUDs, PAPs, like all of this stuff. I could do, and I did colposcopies. The only time I had to use the footrest was the colposcopy. Everything else I did without. Like I couldn't, I was like, I just couldn't visualize, and like you have to see the cervix in a colposcopy, and I couldn't quite figure out. Now, body habitus, like if it's a significant body habitus, you probably can't use this. Also invite your patient to put the speculum in. Why do we have to put it in?
Right, it's like with pelvic ultrasounds, they say
Totally.
put it in.
I have boxes of speculums in my office, and then I will help patients decide like what's the right one for them. I give it to them so that they can practice. And we talk about positioning. Like I do a lot of prep for your GYN procedure or prep for your pelvic, your pap smear or whatever. There's a much better way for us to do it. And we can really, it's so traumatizing for people.
Mhm.
And it doesn't have to be. So
But
food for
that's not how most offices are set.
that's exactly right.
Here, it's just.
Right. So what I say is if they say they can't do it, say, well, you'll be back. Like if you don't have an extra small speculum, get one and I'll be back, or we have to find you somebody else to see. Yeah. Women deserve better.
Is your experience, did you work in women's health and did like OBGYN care and then you?
Yeah.
like,
So
be-
I literally started across the street. I was talking to John. I worked at a federally qualified health center doing primary care for a decade and running the sexual and reproductive health program. Yeah. And managing the abnormal pap case management program, hence the colposcopies. Then about 4 years into that, I was diagnosed with breast cancer and had like horrible dyspareunia. And I was like, I run a sexual and reproductive health program and I don't know how to help myself. Like, what? And most of the medical providers I saw couldn't help me either. And so that's where my passion for the way my clinical practice is now. And another big part of what I do is I help breast cancer survivors navigate all of this, and it's not a hard no for hormone therapy. Local vaginal estrogen is safe for everybody, which is great. Um, and I'm super passionate about like everybody, all my breast cancer people get a survivorship checklist, and we're looking at brain health, bone health, metabolic health, cardiovascular health, all of it, sexual health, mental health, all of it, because who's doing that for them?
It's awesome.
You guys probably are, but like who is doing it for them? It's like, oh, the cancer's gone. And I'm like, no, 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 you get the cancer diagnosis. Here's your checklist, and here's how we're going to support you. And we're going to set up all, we need to think about all these things because hopefully you're going to be like me and you're going to live. Right. So,
What about, I have a 20-year-old girl now, young woman with, she's gonna have she has endometriosis, she's gonna have,
the wide field excision,
yeah.
who's she having it with?
I don't know,
Hmm.
actually.
Okay.
She's in college now
Uh-huh.
at Rhode Island and,
Okay.
I don't know, I just got an email from her the other day saying they confirmed she had endometriosis and she's being referred, so I haven't seen her again yet.
Oh, okay.
But can you speak a little bit about
Yeah.
a young woman like that
Mm-hmm.
and what kind of supports I
So there's
should
a-
direct her to?
Yes, there's a
Her-
great book called Beating Endo that's written by an excision surgeon and a pelvic floor PT. And it addresses all of that. It's wonderful. Highly recommend. And then make sure she's seeing someone who does excision and not ablation. Because do you know the difference?
No,
Okay, so when you have the endometrial implants, when you visualize them laparoscopic, because I've gone in and like been in surgery because I'm like, I need to know about this. And so if you do an ablation, you go in and you simply shear off what you see. If you do an excision, you literally like here's the endo and you cut all around it and you take the whole thing out. So you're getting at the root of it, whereas you're just shearing off the endo and it's going to come right back. So you have to find somebody that does excision, not laparoscopically. And the hard thing is that from a billing standpoint, you get reimbursed the same. So And it's a lot more complicated to do a wide field excision than it is to do just the ablation. It's a lot easier, so it takes a lot longer and you've got a lot more risk.
Yeah.
So not as, it's starting to change, but not as many people are trained in that. And there's my wonderful colleague, Luke Chatburn, is leaving Mount Auburn to start his own endometriosis clinic, and he's the best. They all left. He retired. He's
He
like the
did.
grandfather of what he trained
Yes.
Luke Chatburn. He's amazing, but he retired.
You've got
Cause I had a few patients who went to
Chatburn.
Mackenzie.
Yeah, he's retired though now. And then they had a fellow who also just left and he went to Connecticut. And then Luke is fed up because he's got no support. And so he's opening up his own practice.
What's his last name?
Chatburn.
Chatburn?
Chat, like chat. Yeah. And he's the best. I've been in surgery with him and he's the nicest person in the world. Fabulous bedside manner. Everyone's like, I don't want to see a man. I'm like, but you want to see him because he's so good. It's just the best.
And then I had another patient recently. She came the first time, she has SIBO, so she came through for her SIBO. So
Yeah.
I figured out she has SIBO.
Yeah.
But taking her history, she is chronic, she's 57 years old. She had a total abdominal hysterectomy due to fibroids probably 15 years ago.
A lot of scar tissue.
And she, right, she has SIBO, chronic constipation, and she just had surgery. I think it was in April for an anterior vaginal wall prolapse. And now she has another prolapse.
Mm.
They want to do another surgery.
Mm.
So clearly I should refer her to you.
Yeah. We need to take a good look and see what's going on with the tissue health and check her muscle strength and you know, there's a lot of things we could do. Yeah. Yeah. So, and then the other thing is that I also, like my entry into all of this, nurse practitioners didn't have full prescribing authority yet. So I didn't prescribe. So I'm trained, and when I worked at the health center, running the sexual and reproductive health program, I was awarded a grant called Bringing Awareness of the Pelvic Floor into Primary Care. So I went and did all the training that the pelvic floor PTs do. So, and that's what I like, that's how my main interest started, was in the manual therapy. So myofascial release, I did training in visceral manipulation and craniosacral. So I incorporate that into all of my treatment, which is like I do Botox and then I treat internally, like right after I do the Botox, which is really a great thing. I love that I can do that. So I'd be happy to help her in consultation with you.
Oh, thank you.
Yeah. A lot of food for thought.
Yeah, there's just so many women like I could just think of who I've seen over the years.
Yeah. And like, thank God we have John, right? Who can like help with all these medications. You can't get any of them, you know. And the other thing I don't know that I alluded to, but I do a ton of sexual medicine. So helping really with like not only the hormone piece and like the systemic testosterone and things like that, but there's a whole like I use like oxytocin lozenges. I think about ways to increase the dopamine, ways to decrease the serotonin. I'm a member of the International Society for the Study of Women's Sexual Health. It's a mouthful, ISWISH. And they are the ones who wrote the position statement on the systemic use of testosterone in postmenopausal women. If you guys use that, they're in process of writing an orgasm position statement. But I've gone to enough lectures that I just do all the things that will be in their position statement. So, because I want to empower women in that way as well, right? Like men get Viagra, women get Google and a lot of frustration. And that's not okay.
A question for blood flow. Do you
Yeah.
use any supplements for increasing blood flow or circulation?
Tell me, John, should I be using supplements? I don't know. Like, I always think about like nitric oxide. Like, what do you guys do? Like, I don't, L-arginine.
Things that can increase it. I think both
Yeah.
both companies probably have their pick.
Yeah.
But I was just wondering if you recommend that typically.
I don't typically, but I'm open and would love to learn more. I mean, I always think so I do have a handout about like ways to boost your blood flow naturally, right? Or your libido naturally. So it's like you gotta have a good diet. You gotta have, and I can't remember off the top of my head, but like the dark leafy greens, the beets, like all those things. You gotta exercise. And then I talk about like you might want to supplement with like nitric oxide or L-arginine or something like that.
Citronelle, or
What's the other one?
I think we talked citrus, I can't.
Yes, I think so. Yeah. Yep. Yeah.
I use a lot of LDN for bladder spasms and pudendal neuralgia, and I find people definitely get, it's not enough, but it brings them
Yeah,
up like 25%.
Yeah,
Like, I'll
absolutely.
get 25%.
Yeah,
You
yeah.
have to keep going.
Yeah. Oh, I should also say like for lichen sclerosis and like lichen planus and stuff, I do a ton of that as well. That's because I use a
LDN.
lot of topical
Yeah.
LDN for that. Yeah, sorry. I don't know. Are there other that's
Ubiquinol form of CoQ10 has been shown
shown to
to
help?
have better results than arginine and citrulline.
Excellent.
for
Would love that
increasing
information
IBS.
so I could look
Iron
into it.
was 200.
Okay, great. If you can send it to me, that's great.
Citronelle is arginine, right? Yeah.
Oh, and
But yeah,
quercetin. Yeah, love
but
quercetin.
also, I wasn't sure if you do topical things, which I don't think you have, but like things like
What do you mean?
nifedipine or things that will increase circulation,
Well, so that for like anal fissures and stuff, I do that. Yeah, for sure.
but on the vaginal tissue.
Uh-uh.
No.
No. Do you see people doing it?
No.
No, it's interesting.
Top.
I mean, I do for blood flow, I do topical Viagra, sildenafil, L-arginine, and testosterone. Well, I actually do my own version because I hired a research assistant to look into. I'm like, how do people get what they put in a scream? Do you guys know what Scream Cream? It's the worst name. You got to change the name, John. It's so bad. Right, and some man absolutely came up with that. Yeah, but I'm like, how do you decide? There's so many different ones. Like, how do you decide what goes in there? So, yeah, last year I hired this lovely woman and a master's in public health person, and she did a big literature review. And it was sildenafil, testosterone, and L-arginine had the most. I mean, there's limited science, but what she could find was that. I'm like, okay, well, then that's what mine will be. Because it's nice to have at least a little bit of science behind rather than like, well, anecdotally, we think this is what will work.
It's unfortunate too, because a lot of the science on blood circulation for sexual purposes is usually on men. There's nothing on women. Like I've tried to find research for women and it's like all erectile dysfunction and it's like
Right. So we have to just extrapolate from that, right?
Yeah.
Like that's why topical Viagra. I
Yeah.
mean, I give people oral Viagra too. Right. And I think like with testosterone is a perfect example. Like we have studied it in women, but only for libido. And then like the testosterone doesn't go in and just only affect your libido. Right. It's affecting so many other things. To your point.
Beetroot is big.
Beetroot is big. Yeah. I know like there's that company, oh, they always call me. Berkeley Life.
Berkeley.
They have, is it their nitric oxide? They're always talking about the beetroot powder.
And beetroot acid nitrate.
Yeah. And they have a gum. And their rep was like, oh, the gum before sex. I'm like, really? Like, okay. I mean, if it doesn't hurt, I mean, if that seems benign, you could certainly try it. I don't know. I don't know. Not invasive. I don't know. I think an oxytocin lozenge, we have a little bit more data on that than we do for the nitric oxide gum. But if it works for you, I'm delighted for you.
We actually brought that in for the men's health side and
Which
the
one?
studies, the Berkeley Life.
Oh, you did, yeah,
And then they started doing the women's health side too, and then
yeah.
memory, things like that. So they're just using it for any microcirculation.
I see.
Yeah.
Okay. Well, and they say they have a study that like, we have studies that say that, and it's like a study of 14 people.
Yeah,
I'm like,
I think we helped with the study for brain health.
Oh.
Yeah. It's not,
yeah. But I'm open. Like, if you guys have ones that you recommend that you're seeing benefit, I would love to learn more. It's not something I know a ton about.
Your initial consults.
An hour.
Are you an insurance-based model or are you
No.
private pay?
Private.
And may I ask, what's your consultation fee?
Oh, totally. 600 an hour. Yep. Okay.
I thought the lubricant one is interesting too, because I didn't know that about.
What do you guys carry here?
So we,
Check your osmolality, John.
yeah, I'm gonna go look.
Yeah.
I'll make sure I bring in some
What
of the
do-
other brands.
yeah,
like
what do you-
stuff, 'cause we might as well carry that.
What do you use? What do you guys?
We had Good Clean Love, and we had a lot of people reacting to it, and that's probably something I
It's the aloe, because I called them. I'm like, what is with the burning? And they're like, oh yeah, 5% of the population. I'm like, oh my gosh. Yeah. What do you guys have on, do you know what you have on, like, what do you sell upstairs?
So right now, I think we have Permissive, which is the
Fancy.
Permissive, they came out originally for men for premature ejaculation. And so they have a cream for that, and then they have the lubricants, and the lubricants have worked well.
Okay.
But we have a handful of them. It's nice to know that those people recommend it.
Yeah, well, just, it's like pH and osmolality, make sure it's, and no smell.
Yeah.
No warming, no cooling.
Thank you so
Thank you.
much.
Thank you so much.
Thank you.
Oh, I'm so glad.
Yeah, stop the recording and all that. Who's gonna ask?
All right, perfect. Yeah, I thought it was helpful.
Okay. Take it longer than it would be, but I wouldn't leave until I really felt like I was taken care of. Somebody put me in a side room.
Yeah.
We have a line of help for drivers.
Yeah.
There
That's
have been
for
times,
patients
there,
that are
there,
cancer.
two.
Oh, great. Can you send me
I
that
remember,
info?
when I
Yeah,
was
awesome.
not feeling well.
Have your.
And,
Oh, yes, yeah, I was like, yeah, totally. Great.
Put together by Lisa Alschuler.
Oh, yeah.
She's a driver.
It's like Kelsey was.
She
Great.
knew that brain health and sleep and all these things were impacted by treatment, so
Oh, great. Awesome.
it's pretty cool.
But there's
Thank
like
you so much.
Oh, you're welcome,
Appreciate
thank
it.
you.
Yeah, of course.
It's great.
Yeah, good.
That to be rolled off.
Oh, it's cool, okay, all right, so I was like.
Thanks for the shout outs too.
Okay, yes, okay, so I was like.
Still,
This is the best.